Hello, my name is Haz, and I'm going to speak to you about implantable defibrillators, what they are, and what you need to know about living with one. So, you may be aware that the heart is a muscle about the size of your fist that sits in the centre of your chest, pointing slightly towards the left. Blood flows into the heart on the right-hand side. It's then pumped towards the lungs, where it picks up oxygen. The blood returns to your heart on the left-hand side and is pumped out towards the body. Please use your phone camera to scan this image. It will take you to a page that further explains how the heart works. Within the heart itself, there are cells that are specialised and create a timed electrical signal. These signals travel through the heart from cell to cell, telling them to contract and relax as they go. Looking at this image, you'll see a blue line on the diagram, starting off with the first electrical signal, which is stimulated by the sinoatrial or SA node. This is described as the heart's own pacemaker, keeping time with what the body needs. The electrical signal then travels to the AV node, pictured on the image. This passage of electricity causes the top chambers of the heart to contract and squeeze blood to the lower chambers of the heart. As the electrical signal continues, it travels down the centre of the heart and up and around the walls of the lower chamber, causing them to contract and squeeze blood to the body and lungs. As the bottom chambers are squeezing, the top chambers relax and refill with blood, and the cycle starts again. The normal pathway of electricity through the heart is called sinus rhythm. If the heart beats too fast, we call this tachycardia, and if the heart beats too slowly, we call this bradycardia. Tachycardia and bradycardia are not always abnormal, but if they are abnormal, we may refer to them as an arrhythmia. For the purposes of the presentation, the bottom chambers might also be known as ventricles, and the top chambers may also be known as atria. Not all arrhythmias are harmful or concerning. However, there are two main dangerous rhythms called ventricular tachycardia and ventricular fibrillation. Both rhythms originate from the bottom chambers and send electricity through the heart. Some people may experience ventricular tachycardia and be awake, but they will likely feel symptoms such as palpitations, dizziness, breathlessness, nausea, or chest pain. Ventricular tachycardia may start or stop on its own, but some patients may become unconscious or suffer a cardiac arrest as a result of ventricular tachycardia. Ventricular fibrillation causes cardiac arrest, a medical emergency requiring CPR and defibrillation to abort it. The reason for implanting a defibrillator may vary, but is a decision based on your medical history, scans, and investigations. We recommend a defibrillator if we feel you have had or are likely to have dangerous ventricular arrhythmias that could put you at risk of serious event or cardiac arrest. Some of the reasons for insertion include, but are not limited to, those who have had a cardiac arrest, those who have had life-threatening arrhythmias, those who may have inherited conditions that put them at risk of life-threatening arrhythmias, and those whose heart muscle is stiff, stretched, or weak. Whilst we may recommend you have a defibrillator, this is a decision made with you, not for you. A defibrillator is a small device made up of a pulse generator containing a battery and a small computer. This is connected to wires that sit in or around the heart. The main function of a defibrillator is to treat dangerous ventricular arrhythmias with an electrical shock to restore normal rhythm. It does this by monitoring the heart's rhythm and recognising when abnormal rhythms occur. Any other treatments given by the device will depend on the type of defibrillator that you have. These include subcutaneous implantable cardioverter defibrillators, SICD, implantable cardioverter defibrillators, ICD, and cardiac resynchronization therapy with defibrillator, CRTD. Here is an image of one of our cath labs, which may also be known as operating rooms. This is a lab similar to where you will have your device inserted. The large screen on the left will be used to monitor your heart rhythm and show x-rays of your chest. The arm over the bed is an x-ray machine, which may be used to guide defibrillator leads into the correct position. During your procedure, you will likely be cared for a doctor, nurse, radiographer, and cardiac physiologist. SICDs are the newest generation of ICD and have been around since approximately 2008. In the BHI, they are inserted under general anaesthetic. The SICD is made up of a generator box that sits on the left chest wall underneath your armpit, and a wire that's tunnelled under the skin along the front of the chest. No wires sit inside the heart. The SICD aims to detect life-threatening ventricular arrhythmias and treat them with an electrical shock to restore normal rhythm. They are often used in patients who do not require a device that has a pacemaker function. You must pass a screening before this device is inserted to ensure your anatomy and electrical conduction are suitable for this device. The difference between this and other devices is that there are no leads inserted inside the heart. Instead, as I said, they are tunnelled just underneath the skin along the front of your chest and upwards. It's also not able to deliver pacing for fast or slow arrhythmias where a traditional device may be able to. Again, please scan the QR code, which will take you to further information about SICDs. The traditional ICD has been in use for many decades and is usually inserted under light sedation with a local anaesthetic to numb the skin. It's made up of leads that sit inside of veins that enter the heart and connect to a generator box under the skin just below the collarbone. It's able to detect life-threatening arrhythmias, which are treated with an electrical shock or by the device overriding them with a burst of fast pacing. The way the device reacts to life-threatening arrhythmias depend on how it is programmed. Cardiac physiologists can make changes to these settings, if required, over time. ICDs can also act as a pacemaker to step in if the heart beats too slowly. Please see our other resource to understand more about pacemakers. The difference between this and the SICD discussed previously are this device's pacing ability for fast and slow arrhythmias. The CRTD is again inserted under light sedation with local anaesthetic to numb the skin. This device is made up of 3 leads that again sit inside veins that enter the heart and connect to a generator box that sits under the skin just below the collarbone. 1 lead will sit in the top chamber of the heart, 2 leads will sit in either bottom chamber. There are 3 main functions of a CRTD. A pacemaker function to treat slow rhythms, a defibrillator function to treat fast and dangerous rhythms in the same way as a standard ICD, and also a function that improves the overall coordination of the heart's lower chambers. This device is often used in patients with heart failure to improve overall heart function and the symptoms associated. However, some patients do not feel an obvious benefit after this device is inserted. There are some risks associated with these procedures, as with any operation that you may have. The risks of the procedure may vary and be individual to you. The main risks are on the screen here. These will again be discussed with you at the point of insertion, and you will be asked to sign a consent form. This slide talks through what to do in the event of a shock. If your device detects a life-threatening arrhythmia, it may decide to deliver an electrical shock. We are told that an ICD shock feels like being suddenly kicked or punched in the chest. It may be painful, but will only last a few seconds. If your heart is beating very quickly, you may have become unconscious before the shock is delivered. If you have 1 shock from the device, but feel well afterwards, please call our cardiac physiologists and tell them what's happened. They may ask you to send a download from your remote monitor. If you have 1 shock from the device, but afterwards feel unwell, please call 999. If you have more than 1 shock in a row from your device, please call 999. This slide will talk a bit about recovery. Most patients will go home the day or day after their device is inserted if they are medically fit. You may require a chest X-ray to confirm the position of the leads before you go home. It is normal to feel some discomfort around the insertion area. This should get better over time. If you have an ICD or CRTD, you must restrict your arm movements for 6 weeks to allow the leads to embed in the correct position in the veins around the heart. It's normal to be able to see a faint outline of the device underneath the skin. This will vary depending on your body weight. Any concerns about the device should be reported directly to the physiologists or arrhythmia nurses depending on the issue. This slide contains information about wound care, and it's important that you also read the leaflet given to you, as this contains essential information. Your device insertion wound should be kept dry for 7 days. After the first 5 days, you will be able to remove the top layer of dressing. After the full 7 days has passed, you may get the wound wet, and any residual paper stitches will begin to peel off when they are ready. Please do not pull these off before they start to peel. If you have any closing sutures, you will be advised when and how these should be removed. It's important to note that if you notice the wound has become red, hot, oozes anything, or has not healed, that you contact the arrhythmia nurses as soon as possible. If the device becomes more prominent than usual, or the skin over it becomes stretched or thin, please contact the arrhythmia nurses as soon as possible. If there is any sudden swelling over the device, or the device starts to bleed, you should attend your local A&E department or ring 999. The following slides are produced by my physiotherapy colleague and will talk through arm movements that are safe to do whilst keeping your ICD or CRTD leads in place for the first 6 weeks.
Hi, I'm Hannah. I'm one of the physiotherapists at the Bristol Heart Institute. This is a few slides and a short video to show you how to prevent your shoulder having problems after your pacemaker is inserted. After your pacemaker, you are allowed to move your arm freely within the limits of pain. On your affected arm, we advise avoiding movements that produce an extreme stretch of your arm, for example, reaching out in front of you or reaching out to the side. This is in order to help the leads of the pacemaker embed into your body, and we advise that you follow these restrictions for approximately 6 weeks. So other things to avoid are swimming or golf and pushing and pulling heavy weights. Whilst we want to protect your new pacemaker, it's also important not to let your shoulder become stiff and hard to move. Here are 4 exercises that you can do safely after your procedure. First exercise, the pendular exercise. Leaning onto a table with your good arm, letting your affected arm dangle forwards and in front of you. Using gentle movements of your body, let this arm swing forwards, backwards, side to side and in circles. The more you lean your body forwards, the more of a stretch your arm will have. Neck stretches. Start in a seated position, looking straight ahead. Look down towards the floor, moving your neck, and then look up towards the ceiling. Look over your right shoulder, and then look over your left shoulder. Move your right ear down to your right shoulder, and your left ear down to your left shoulder. Try to keep shoulders down and relaxed at all times, and hold each position for 10 seconds. Shoulder shrugs. Sitting down, roll your shoulders forwards and backwards 10 times each way. Shoulder external rotation. Keeping your elbow close to your body, gently rotate your arm out to the side and hold it there for 10 seconds. Repeat this 5 times. You can add in holding a walking stick or a broom to help with the stretch. You should aim to do these 3 times a day to prevent any problems developing. Recognising a shoulder problem. So these gentle exercises should be enough to prevent shoulder problems happening, but if you feel arm movements are getting harder or getting stiffer or more uncomfortable at your shoulder joint, you should go to your GP and seek a referral to physiotherapy at your local department. If there are any issues such as redness or infection or pins and needles, you should contact the EP department.
Moving on to follow-up. You will have an initial check at 6 weeks post-device insertion, which is a face-to-face appointment with the cardiac physiologists. After this, we may be able to refer you to your local centre for further follow-up depending on the type of device that you have. You will also be given a form of home monitor, either a plug-in device or a mobile phone app, which will download information from your device and send it to us. You will be seen at least yearly in the device's clinic, but should also have condition-specific follow-up depending on the reason for your device insertion. The average device lasts between 7 and 10 years. The more it is used, the faster the battery depletes. We will usually replace the hardware that contains the battery, but leave the leads in place. When you have had roughly 1 year left on the battery, we will contact you and arrange for you to attend hospital for a battery change, which is a short day case procedure. Moving on to living with an ICD. You must inform the DVLA if you have had an ICD inserted and the type of device. The reason your defibrillator was inserted will dictate the initial time that you were asked not to drive for. This will vary between 1 and 6 months. If you receive a shock or other therapy from your device that is associated with or likely to cause incapacity, this will incur another driving ban. Depending on your job role, you may need to find that you take time off work after insertion, particularly if you have a job that involves driving or heavy lifting. When you return to work, you may need adjustments that allow you to continue in your current role. Electromagnetic impulses and magnets can temporarily interfere with defibrillators. They can be impacted by the electromagnetic fields, which do not damage the device permanently, but may stop it from being able to read your heart rhythm. In day-to-day life, examples of where this may occur include with mobile phones, induction hobs, and microwaves. Some larger appliances must be avoided completely. We'd suggest you get in touch with the cardiac physiologist if you have any specific queries. Your ability to exercise will depend on your underlying heart function and diagnosis. We would suggest you get in contact with your team to discuss this in detail. If your condition dictates, there may be some exercise that you can not take part in at all. Contact sport should be avoided where possible. This is to protect the device itself and also the skin around it. Living with a defibrillator can have an impact on your psychological well-being, and you may need some time to come to terms with it. It's normal to feel that you're more anxious about your heart rhythm, particularly after the ICD is inserted or if you ever receive a shock. The arrhythmia team can offer informal support and talk through your experiences, but if psychological help is required, you would need a referral to your local community mental health services. Often, these are services that you can self-refer to. Please discuss this with your GP if you wish to hear more details. Moving on to family planning. If you're a person of childbearing age, it's important that you discuss pregnancy planning with your cardiologist. You may need to be seen in a maternal cardiology clinic and have your medications adjusted through pregnancy. Some conditions may be inherited, which is something to be considered when planning pregnancy. Finally, it's important to understand that a time may come in your life when a shock from the defibrillator may no longer be appropriate. This can include in the event of a life-limiting diagnosis or when receiving palliative care. Deactivation of the defibrillator turns off the shocking function of the device, which is a painless and non-invasive procedure. If you have the capacity, you can make this decision for yourself, and we will arrange for deactivation of your device. We will usually want to talk through your wishes and make sure you understand the implications beforehand. If you do not have capacity and have not got an advanced decision in place, We may make a decision in your best interest after speaking to those close to you and the medical professionals that know you best. These 2 QR codes will link to websites that talk in more detail about arrhythmias. The British Heart Foundation and Arrhythmia Alliance websites have valuable information about heart conditions and the type of device that you will have had inserted. The contact details on the screen now will be useful to you in the event of both an emergency or for a non-urgent query. 111, 999 or attending your emergency department are the most appropriate if you need urgent medical attention. For non-urgent queries, particularly relating to your wound or your device, you can contact the arrhythmia nurses or cardiac physiologists on the numbers on the screen. Thank you very much for listening.